Hey everybody, welcome to our next installment of our special series here on sports medicine and acupuncture. This is our Shop Talk summer series. Good time to be doing sports and a good time to be taking care of people that are banging themselves up or need some help. I'm really excited today. I've got Brian Lau with us, and we also have Grant Rettison. Brian is an acupuncturist. He's been doing sports medicine since 2000. Background in structural integration. He's been doing that since 2002. Holy smokes. Ever since the beginning of the century. And Grant is a student. It goes by fast, doesn't it?
Makes me feel old.
I know, it's crazy. And then we've got Grant Rettison. He's a student at a local acupuncture school. He's going to be the model for today and joining Brian soon and doing some acupuncture with some sports teams. So welcome to the profession. The thing that we're going to be talking about today is adjunctive therapies to bolster outcomes in sports medicine. And Brian does a lot with myofascial release work and a lot of work with sinew tendons. And so we're going to get into this with a little bit of show as well as tell. Brian, when did you start using myofascial release in your sports medicine work? How'd you get into this?
Yeah, so that predates my work with acupuncture. So I initially got into this kind of work with qigong and tai chi practice and all of that. And they used to discuss tendons, various tendon changing exercises. And they would talk about these tendons that go up the periphery of the body, up the arm or something like that. Well, in the West, those aren't tendons. We think of tendons, these little cord-like attachment of the biceps, for instance. So it was more of these planes of connective tissue and such, which led me into structural integration initially through the work of Tom Myers and anatomy trains. A lot of people know his system. He talks about a lot of these myofascial planes. So he's was a Rolfer initially, taught with the Rolf Institute, and then has his own structural integration program. So it just led me into structural integration. In structural integration, we use primarily myofascial techniques. There's a system that differentiates structural integration from just straight myofascial work in that they have a series of sessions and they have sort of protocols and goals and stuff like that. More of the overarching paradigm or the system of structural integration. But the techniques they use are myofascial techniques. So as I got into acupuncture, it just has always been a part of my toolbox, and I developed kind of a system for using that and putting it into place for the sports medicine acupuncture program, and we utilize a lot of myofascial techniques in that program, kind of based on structural integration, but obviously we're not going to spend as much time as someone who's just doing that, because we're also doing acupuncture and other things too, of course. So it's how to layer it in, basically.
Yeah, layering it in, that makes a lot of sense because it's something that you already know. It's something that you can add. I find it so interesting. Whatever work we've done before we came to acupuncture, apparently we throw none of it away.
Mm-hmm.
We find these ways of integrating it into what we do.
Yeah, for sure. I feel like sometimes what happens, especially with things like myofascial release, orthopedic evaluation, I think I could say this also, is sometimes we sort of put on a different hat, and it's okay, I have this Western hat on now, and I'm going to apply these techniques, and we kind of step away from the channel system. So I've tried to put a lot of emphasis on keeping it in the language of the channel system. And if you're doing an orthopedic evaluation, you're doing Thomas tests, and you have a short psoas, well, which channel is that affecting? Which channel is that sort of testing, so to speak? And using sort of the channel sinews as that mechanism to be able to interpret ortho evaluation, or using techniques like myofascial so that they can kind of integrate seamlessly with the acupuncture instead of it being sort of like a side hustle or something, if you know what I mean.
Yeah. Well, it sounds like it integrates really well.
For sure.
In part because you've seen how both these systems work and you've been able to pull it together in your own, mind, in your own experience. But also, if I'm hearing you correctly, you're using it in some ways for diagnostics. And at the same time, you're also using it for treatment.
Mm-hmm. Yeah, for sure. The question always comes when people are, especially if they haven't done a lot of manual work, when to do the manual work. Do you do it before acupuncture? Do you do it after acupuncture? I don't think there's really a right or wrong answer. But one advantage of doing it before, there's certainly advantages to doing it afterwards, and we can talk about those too. But an advantage of doing it before is you're kind of warming up the channel. You're kind of moving and mobilizing. You're assessing, does this match what I found with maybe other orthopedic evaluation or movement or range of motion test or whatever? Am I feeling sort of what is consistent with what I was finding? Sometimes you do. Sometimes it's like, that's a lot more stuck than I realize, a lot less pliable, a lot more rigid, or, whatever word it is for that particular person. Also, which way the tissue moves or doesn't move, that can give you indications of which, angle to put the needle in. If the tissue moves really well this way, press it maybe towards the dorsal surface of the arm, and it just doesn't mobilize that well. Well, I kind of want to have the needle progress through that tissue in that same way to help influence movement. So it gives you direction, I guess. It gives you direction in terms of up, down, side, medial, lateral, whatever. So that's an advantage of doing some work before. It's sort of somewhere between assessment and actual treatment. Starting the therapy, but you're also gathering information and putting it into context.
Yeah. It sounds like you're taking the guesswork out of it. Instead of thinking about, here's a problem, here's an elbow or whatever, shoulder. Here's a problem, here's how they're presenting. It's this channel. Maybe I should do this. Maybe I should do that. This theory says one thing. Here's another theory says another. No, you just kind of put that to the side, put your hands on what's here.
Yeah. It does it makes you pretty much in the moment, I think, is what you're saying. And I agree with that.
Well, can we get a demo of the work you do?
Sure. So let's do, why don't you get shirt off? I hadn't had him take his shirt off, but I'm going to get you face up. I'm going to do something on the leg instead. So that'll work. Now, I would maybe should have planned a little bit better and had shorts. I should have mentioned that, but that's okay. I can still get the same idea with this. So let's say he was coming in for chondromalacia, patellofemoral syndrome. The patella is not tracking well, starting to get wear and tear on the patella. So you have the two structures really that are most predominant on this would be the vastus lateralis, the lateral quadriceps. They kind of blend in with the retinaculum on the side of the knee, and then the vastus medialis on the medial surface. And both of those can kind of pull the patella one way or the other when there's imbalances. And I would say it can go either way, but more typically, that vastus lateralis becomes very rigid and very sort of firm and overactive. And let's see if I can make sure I'm out of the camera here. Maybe as I'm palpating and pressing on this, it also feels like it's pulling the patella up and lateral. I can assess that at the patella, but when I'm actually putting my hands on the tissue, it feels like it's pulling up. So, I want to be able to sort of move that tissue downward and descend that tissue to sort of unwind, to unwrap the patella. Now, of course, the nice thing about this when we're in the Chinese medicine world is I can correlate that with other findings I had. Maybe he had acid reflux, for instance. So I'm finding some rebellious stomach qi signs, or I could ask him if I didn't have time for a full eval. I can, kind of say, oh, geez, I noticed this tension and this lifting, this sort of direction of sort of pull upward on the stomach channel. And I know I want to descend it, but I kind of want to see, does he have some signs of rebellious stomach qi? So those would be all indications where I might have my hands on and it starts giving me information. Whereas another patient, maybe I notice that there's sort of a lack of tone on the medial side, and it's more about spleen deficiency. That might correlate with some spleen deficiency signs. And same thing, I might want to, instead of dropping that tissue, I might want to lift the tissue and kind of spread upwards, or do a combined technique where I'm kind of lifting and dropping and, descending the stomach channel, or at least the sinew channel, while I'm lifting and raising the spleen channel. So those would be indications where my hands-on starts to broaden my information that I've already gathered, and maybe gives me some thoughts of what I might also want to ask the patient. Same thing, maybe lateral epicondylitis. Let's see if this shows up. And as I'm kind of pressing through this mobile wad of 3 on these structures I'm going to scoot you down just a little bit. There we go. Just so it's on the camera. Yeah. Brachioradialis, extensor carpi radialis, longus and brevis. As I'm kind of working with that tissue, again, it might feel like it's pulling up and kind of really bound to the lateral epicondyle, or it might feel like that tissue doesn't move away, doesn't spread, and it's not as mobile as it could be. So as I'm pressing on the tissue, I note that there's that lack of pliability. And then as I work up it, I might say, oh, yeah, right in there, I start to notice that extensor carpi radialis brevis is really taut. Maybe it'll even start to fasciculate a little bit as I'm pressing on it, which actually is a little bit on him. I don't think that'll show up on camera. But I'm noticing a little bit of a local twitch response just from the pressure. So I know that that's going to be a useful point to include. It's kind of a LI10 region, I guess. I didn't measure it, or I didn't go, strict Sun measurement, but I can tell right in that area. You probably feel a certain amount of sensitivity on that.
Yeah, it looks like LI10.
Yeah, it is, but I wasn't, going to LI10 necessarily. I just, through palpation and finding it and noticing that the tissue changes, that's where it kind of led me. So then that would...
Brian, I'm noticing as you do your palpation that you're also at moments going into some kind of treatment mode. Watching your hands, and for people listening to this, you can see the video over on the Qiological website, because this has all been videoed, and you can see how Brian is putting his hands on Grant. But I'm watching you. This is really cool that you're listening with your hands, what's happening here, and then almost immediately having this response. You go in with your knuckles, you go in with a finger. You kind of change back and forth between diagnosing and what appears to be treating.
Yes, yeah, exactly. So, because you're getting findings from kind of where the tissue moves, where it doesn't move. Oftentimes with myofascial release, there I was doing more pressure, but then I might eventually, maybe I'll come back after the treatment, and I might work on descending this whole layer. So I'm going to sink in. We'll talk about some goals and technique here in a second, but I can start to work on descending that whole kind of plane of tissue. So that palpation gives me a sense of, does it feel like that plane is pulled upwards? Does it feel like it's pulled downward? Does it feel like there's a lack of ability for that mobile wad of three, which is, again, those three muscles, extensor carpi radialis, brevis longus, and brachioradialis. They're very mobile. You can grab them and move them around, so they're called the mobile wad of three.
You just called that mobile wad of three?
Yeah, mobile wad of three. That's just a name for these like very mobile. You can grab it on yourself, and it should be very mobile. But the point is that sometimes it's not so mobile. Sometimes it's the immobile wad of three, I guess. So you want to return that mobility. So am I moving it towards the radial side? Am I descending it down towards the hand? Am I lifting that layer? Those are things that I'm trying to sort of feel through my hands as I'm working. And a lot of it is like, which way does the tissue move and which way doesn't the tissue move? And to be honest, sometimes just placing your hands on, you can kind of sense, I guess, for lack of a better term, energetically, you can sense sort of the pulls through the fascia, the fabric of the body. Does it feel like that fabric is pulled up, or does it feel like it's pulled towards the Sanjiao channel? Does it feel like it's, stuck in that space between those two channels?
So I got a question about that, because it looks like you're working with the sinews here.
Yes. Mm-hmm.
In the connective tissue. And it seems to me, and I've heard other people talk about this, and I've noticed it in my experience, that sometimes you can put your hand on and you tune in a kind of a way, and it's weird, but you can feel pulls to all kinds of different places. Mm-hmm. Can you tell us a little bit about that? How you learn to tune into that kind of thing? Because it really seems to be something that the sinew channels in particular will communicate with you when you tune in.
Yeah, and it's not just the sinew channels. I mean, a lot of my start with this is studying visceral manipulation, which is an osteopathic modality, and they do a lot of what they call local and general listening. General listening, they come and they put their hand on the head and they try to feel sort of where the primary pull is in the body, where it leads, and how it maybe warps the body. But the local listening, they might just come with their hand on and, again, feel for, like, does it feel like that pull of the liver is taking you sort of in a certain direction? And there's indications. You learn some meaning to when you feel various pulls in different directions, which organs it is. But it's the same with the channel sinews and the fabric of the body. It's just like this sheet here, of that sheet's pulled down, and I put my hand on it, I can kind of feel that sort of sense of where that pull's coming from and which direction it's leading to. And then you just have to kind of trust yourself and put it into perspective from other findings that you have. It's like anything, like pulse, subjectivity there, but hopefully it should be painting some kind of consistent picture with other findings that you have. And if it doesn't, then you have to sort of have that dialogue with yourself. But that's it. It's just to kind of note with a little bit of gentle palpation, movement and mobility, where the pulls are and where the tissue is yielding and where it doesn't yield. An analogy I use a lot when doing this work is, canoeing. So when you're doing the work and you're working against the direction that it's pulling, you want it to feel like you're going upriver. And by that, what I mean is when you're going downriver with the canoe, it's almost like the water's getting away from you. And there's plenty of times where I'm doing work and I feel like it just feels like a very awkward technique as I'm spreading through the tissue, because it feels like it's like I'm going upstream, so to speak, and I can't lock onto the tissue. Whereas if I change around and say, oh, now there's a little resistance. Now there's something for me to lean into, to sort of give me resistance in a good way. It kind of gives me something to sort of support myself, and the technique feels normal. It's definitely a trick I have when I'm teaching techniques in a group, because I might be doing it in a particular direction that I have in the notes, but I'm like, this person, it doesn't match their tissue. It feels awkward when I do it on them. I would have to do it this way on that person.
That's interesting. So there's a difference between push and pull.
Yeah. You want to feel like you're kind of, you have something to lean into, like you can just, relax your weight into that and kind of gradually start to lift and move the tissue. And there's certain structures where you're doing that. It just doesn't feel like it's, like maybe, for instance, if the rib cage was rotated and I'm moving the oblique fascia that way, where it's already going in that direction, it feels like it's getting away from me, and it feels very awkward if I misassessed. Whereas I change, it's like, oh, now there's something to push against to sort of unwind, the body and kind of take it into a more normalized position.
Yeah, there's a sense of engagement that you're looking for.
Yeah. And sometimes you catch it. Sometimes you make, just like anything, it's like you kind of take the wrong path and you're like, nah, this doesn't feel right. I need to reassess. The tissue doesn't feel like it's, it doesn't feel like I have that something to lean into.
That wrong path thing, I'm glad you bring it up, because it seems so often in the work that we do, we're trying things out. Does this fit? Does it not fit? Is it connecting? Is it not connecting? I really like what you say about making sense of it in conjunction with the other findings that you have. It's like there's very little. I mean, maybe there's something that by itself you go, oh, yes, this is that.
Yeah.
It's nice when you find it, but often it's more of a conglomerate of things that you've noticed.
Yeah, it happens, but...
Have you found that to be the case, or?
Yeah, for sure. Yeah, now and then you get it, just like somebody comes in and says something and you know exactly what you're going to find, and everything seems to match, and it's, it's like textbook, but it's not as typical that way. There's a lot of sometimes conflicting information, and you have to sort of take all of that and make a strategy and then reevaluate. Sometimes you're on, sometimes it's like, it wasn't quite right.
Okay. So you come up with an idea, you try it out, and then you go and you test it.
Yeah.
And it's just, it's this constant iterative process.
Yeah. For this work, one of the nice things is what you are looking at is, does the person look taller afterwards? Does it look like they have more length in the body? Are they moving better? If you did certain tests, do those tests change? There was a positive test on an orthopedic test or a manual muscle test that was testing weak. Does the muscle start to fire better? So there's some things to check yourself, but also, like I said, in the moment, you can kind of feel like what you're doing, I don't know, it just has the therapeutic feel versus like, this doesn't feel like I'm affecting the tissue in a positive way. I don't think it's hurting it, but it's not doing that unwinding that I'm looking for.
Tell me a little more about this unwinding. I've heard the term.
Mm-hmm.
And certainly people come in and they talk about how they're knotted up or they're stuck. I mean, people use this language. Unwinding sounds like the antidote to a lot of problems.
Yeah, for sure. Yeah, again, I think it's a lot of it is really looking at especially the fascia as a fabric. And I'm going to take this mic off here. The fascia is a fabric, and if that fabric is pulled a certain way, and I want to sort of move and widen or lift or, rotate or whatever, I want to sort of move that fabric. I want to shear that fabric. That's sort of a lot of the goals with the myofascial work. And a lot of that shearing is very important because a lot of people say it breaks up adhesions. Well, I don't think that's quite right and doesn't really play out in research. But the hyaluronic acid in the body and the connective tissue can kind of aggregate and stick together and lose hydration, and that can get very densified is a lot of the terminology that's used. And that shearing motion that you get on the fascia as you shear the fascia, that helps, I guess, I don't know if it breaks up adhesions, but it helps move those those that molecule apart, so it's not all aggregating, and it helps return fluid to that hyaluronic acid.
So you're improving the local fluid metabolism in that area.
Yeah. It kind of gives a little more hydration and allows those surfaces to glide. And that's what you're looking at, is these nice gliding surfaces. I do a lot of dissection, teach dissection in the sports medicine acupuncture program. So I get an opportunity to do that quite a bit. I do it with the the University of Tampa with the PA program. Multiple dissections that I do a year. And you get to see a very big discrepancy between these gliding and sliding surfaces from one person to the next, where sometimes it's, that blade is absolutely necessary to remove that stuck glommed together tissue. It's basically become one tissue versus, something that should be gliding and sliding. Not that there's not fascial connections there. You want those fascial connections because that helps inform the body mechanically, but at the same time, you want them to be able to move individually. And that's one advantage that the manual therapy, I think the myofascial release has, that I think can be really useful in an acupuncture setting, is it helps to kind of reestablish those gliding surfaces between, say, like the vastus lateralis and the rectus femoris, or between that mobile wad of 3 and the finger extensors. You could say between the large intestine sinew channel and the Sanjiao channel. There should be a certain amount of ability for those to separate and glide and slide and all of that. So the myofascial techniques are very much based on that gliding aspect. So when we do the work, we don't use a lot of lubrication. It's not just like a bunch of oils, because then you're compressing the tissue, which is fine. That's therapeutic in its own right. But you want to sort of have a little bit of a grab, a little bit of a pull on the tissue. So we either use anywhere from no lubrication, where I'm just sort of like sinking down to the level of tension and then, moving it in a particular direction. Or I might use just very, very small amount of, I use this Palmer's cocoa butter, where you can get it like Walgreens or whatever, but it's not much. I mean, when I use it, it's, something like that. And I don't even usually put it on the person.
But yeah, little dab will do you.
Yeah, it's just more like just to take away a little of that friction on the skin, so it doesn't feel like you're kind of rubbing the skin and all of that. But usually when you get the right depth, the skin is a lot more comfortable. So I want to have that sort of dropping down perpendicular into the tissue to establish the depth. And then it's just this slow sort of shearing force that you're adding. It's like you're scooping, like you're engaging the tissue and lifting or dropping or moving, and just kind of like taking your time, really. And you don't have to do a whole lot of passes, but it's that shearing that's very key for this type of work. So that shearing is going to give you that change in the tissue, that more fluidy, glidey quality to the tissue. And again, that could be done before and then acupuncture afterwards, or you could take out the needles and do it, after the acupuncture.
And do it after.
They complement each other really well.
It looks like they would. Again, I'm quite struck with how you very fluidly go between assessing, treating. It looks like one complete whole, a whole yin yang of listen, affect, do a little, listen a little. It's quite lovely. It's funny. We all have stereotypes about almost everything. And when I think of sports acupuncture, often I'm thinking of, there's some deep needling and there's, trigger releases and, all this stuff. And I'm watching what you do here, and it's like, this looks like my friends who do Japanese acupuncture. They put their hands on, they're listening, they're assessing, a little bit of work here, a little bit of work there. This is super hands-on.
Yeah, and I might sometimes pull a needle out and do a quick, I do retain needles, but not always. So I might do a quick bit with a bit of work with a needle and then come back and, follow through with the stroke. So it is like sort of a back and forth.
Yeah, it's lovely work. It's fun to watch. Again, if you're listening to this on the podcast and you want to see it, it's over on the website. It's really worth watching. Brian, how do people get in touch with you if they want to learn more about this, learn to do it? Where do they go?
Yeah, so I teach with AcuSport Education. Some of the classes are the Sports Medicine Acupuncture Certification, which a lot of people know that term, SMAC. The company that overrides that is AcuSport Education. So we have some other classes outside of the certification classes, and I teach some of those in particular where we do a lot of myofascial work. Right now I have a trigger point class that's going to be coming up in Bradenton, kind of Tampa area of Florida. That's kind of morphing into, I'm using a lot more manual techniques than just trigger points. I need to rename the class actually, but it's that, kind of back and forth between manual and needling techniques and a lot of palpation. It's a very palpation heavy class, primarily focusing on that and feeling for those like pulls in the tissue and using some mobilization techniques and needling and kind of combining. It's very much a technique class, if you know what I mean by that. It's not like a full system like SMAC is, where you learn, all the orthopedic evaluation and such, but it's more like something you can just apply right into your practice. So that's a class that features a lot of this myofascial work.
That sounds great.
But I also have a YouTube channel. It's Jingjin movement training, Jingjin channel sinews. So I do a lot of qigong on there, but I also do some myofascial work. So if you wanted to check that out and subscribe to that, that's something I've been putting a lot of effort into recently.
Great.
So those are the two main places.
I'll make sure that all of that is over on the show notes page.
Great.
So people can just go right to it. Brian, thank you. And Grant, thank you. And good luck with your new career.
Thank you.
Really appreciate the time today. And man, I might have to come down and get my hands on some people with you. This looks really like delightful work, actually.
Yeah, thank you. Yeah, I don't think it should be, it can be intense at times, so like a lot of sensation, but it shouldn't be like painful. Or, I think you have to be mindful of the limits of the body and just listen to the body and not force things. That's generally the flow I have with it.
Yeah, that's our job, isn't it? Listen to the body.
Yeah, for sure.
All right. Well, thanks, guys.
Sure. Thank you for having us.
When practitioners reach for a Chai Hu Guizhi Tang or Xiao Qing Long Tang, they need quality that they can trust. Lhasa OMS supplies the herbs your clinic needs to be ready for the cold and flu season. Visit Lhasa OMS to source the classical formulas featured in this series. Use the code REMEDY20 for 20% off your next purchase at LhasaOMS.com. Some exclusions apply. See the website for details. That's it for this episode of Shop Talk. Did you learn something that brought a patient to mind? Don't keep a good thing to yourself. Share it with a friend. They'll be happy that you did. And tune in again for our next episode of Shop Talk.